Before we start, I'd just like to make an acknowledgement of country as well. So I'd like to acknowledge the traditional custodians of the land wherever we are gathered today. I'd also like to pay my respects to elders past and present and extend that respect to other Aboriginal and Torres Strait Islander persons who are present today. So in terms of giving you a little bit of background before we start, I've had the pleasure of working with Stephanie for many years now, and she's the research coordinator with Orygen, the National Centre of Excellence in Youth Mental Health. So she's had experience in evidence mapping and evidence synthesis. And so she coordinates an open access online database that consolidates all controlled trials and systematic reviews published in youth mental health since 1980. And that database can be found on Orygen's website as well under the Evidence Finder tab. So Stephanie has clinical experience in working with young people with psychosis and with borderline personality disorder and in chronic medical conditions and cancers and in perinatal mental health. And she's currently working in psycho-oncology at the Royal Melbourne Hospital with both young people, adults and their families. So she mixes that clinical role with also her research coordination role here at Orygen. And myself, I'm a psychologist and a senior research fellow with Orygen, and I've been involved in early intervention research for a while and worked as a clinician in youth mental health services for the past 10 years. So today's webinar, we've got some objectives that we'll be working through with the content over the course of the next sort of 50 minutes that we've got together. So to start with, we want to provide an overview of social anxiety and how it presents in young people. Then we'll move on to reviewing the latest evidence for CBT in the treatment of social anxiety in young people. Steph will also work through potential moderators of treatment effect and differences in outcomes between group-based and individual therapy, and explore the evidence for non-CBT treatment interventions that have recently received some interest in this area. So just to let you know, I'll be starting off with some information, and I'll also pop back in at the end with the case study, and then in between, Steph and I will switch things around and she'll be providing the overview of the evidence. So you might just have to bear with us as we change seats throughout the course of the webinar. So if we're looking at the diagnosis of social anxiety disorder, it really centres around this discomfort in social interaction and concerned about being embarrassed and judged by others. And so this discomfort will be experienced as fear and anxiety and will be accompanied by autonomic arousal as well. And so it can range in severity to a discomfort which can be sort of circumvented and adapted to, right through to virtually disabling fear that actually then infiltrates into multiple areas of life. And that discomfort then can generalise to routine activities too. So people with social phobia do desire social contacts and they want to participate in social situations, but their anxiety can be unbearable. And so it leads to social isolation and either the absence of development of social skills, and which can also intensify their existing anxiety too. So some recent changes in the DSM-5 is that there's a specifier added in for performance only. So if the fear is restricted to speaking or performing in public, and there's also some specifiers around selective mutism that have been added in as well. But I think probably the biggest thing, and the thing that we'll be focusing on when we're talking about what's effective in interventions, is about what can be done to circumvent that avoidance of situations. So it's sort of the avoidance of situations that maintains the social anxiety disorder in people, and it feels as though the avoidance actually helps with the discomfort or tension, but as we'll get to it, we can see that the avoidance itself can become very problematic. So the prevalence of social anxiety disorder in young people is at an estimated 12-month prevalence of about 7% in both children and adults. But the prevalence does vary between studies, and it depends on the assessment that was used, and it can also vary cross-culturally as well. The typical age of onset is during late childhood or adolescence, and 75% of people who develop social anxiety disorder report an age of onset before 16 years. The median onset age is 13. The prevalence is higher in females than in males in older adolescence, and the prevalence is higher in older adolescence or young adulthood than it is in late childhood. And it's one of the most prevalent psychiatric disorders. The characteristics of social anxiety in young people. The symptoms are particularly widespread amongst young people. Because of this, sometimes most children and adolescents can go unrecognised by parents and professionals. It's most commonly a fear in both adolescents and adults is public speaking. However, isolated social fears occur very rarely. The symptoms are particularly widespread among young adults, both in clinical and non-clinical samples. The majority of people with social anxiety disorder do not obtain treatment, and those that do wait more than 15 years after onset to seek treatment. So we can imagine what would happen in that time in terms of how much potential damage is being done to their functioning with such a long treatment delay. And without intervention, it's likely to run a chronic course. There's a high degree of comorbidity, and it has those significant impairments, as I just mentioned, in multiple domains: academic, social, and occupational functioning. So I also mentioned that comorbidity is common. So some of the frequent comorbid conditions in young people with social anxiety disorder are other anxiety disorders, specific phobia, agoraphobia, separation anxiety disorder, and generalised anxiety disorder. It's also highly comorbid with mood disorders, sometimes with externalising disorders such as oppositional defiance disorder, and also substance use. But what the literature actually does find is that social anxiety disorder precedes, more often than not, the comorbid condition, with the exclusion of specific phobia, which tends to start in very early childhood. So when we think about this, it has some implications for assessment when we're working with young people and carefully going through an exploration of their history of their mental health difficulties, because they might be presenting with another disorder by sort of late adolescence or early adulthood, but perhaps there has been a long-standing issue with social phobia. So some of the associated difficulties, I think I can probably, before I talk through this slide, actually just say in summary that the lifetime impairment associated with social anxiety disorder is significant, which really highlights the need for early intervention and appropriate treatment in young people. We can see that there's significant impairments in productive role. So in adolescence, it may mean that young people leave school earlier than they normally would have, or perhaps they have lower levels of educational or professional training. And over the lifetime, we can see in adults who have a long-standing history of social anxiety disorder that there's lower work productivity and income level, higher rates of unemployment, and financial dependency on others. And in terms of impairments to relationships, across the lifetime, people with social anxiety disorder are less likely to perform social roles in the community and to be married, more likely to have difficulty maintaining a marriage, and more likely to live with their parents during adulthood and to have dissatisfaction with friendships and social activities as well. And apart from these sort of functional impairments, social anxiety is also associated with attempted suicide, drug and alcohol dependencies, and including heavy smoking during adolescence as well. So we can sort of see a range of difficulties that are associated with this disorder. An important question to consider is, does social anxiety present differently in young people compared to adults? The physical symptoms of adolescents and young adults are similar to adults. So the autonomic arousal, increased heart rate, blood pressure, the blushing, nausea, trembling and sweating are consistent across age ranges. However, we do notice that there's higher rates of avoidance in adolescents than in children. And so it could be potentially explained, this avoidance, by a typical development trajectory of friendships and social engagement. So during childhood, parents tend to have significant control over their child's participation in social activities. They might arrange the play dates or enrol their children in extracurricular activities, for example. But during adolescence, the increase in independence that young people are showing and the pressure to participate in peer interactions includes them developing their own responsibility for initiating and maintaining social engagement. So less parental control may permit adolescents to start avoiding situations that they have found distressing. And adolescents may differ from children with social anxiety disorder by presenting with externalising problems as well, thinking of problems with their behaviour, fighting, skipping school, and some covert antisocial behaviour as well. So just before I hand over to Steph, I think probably the essence of coming out of that information about the prevalence and the presenting issues and the comorbidities associated with social anxiety disorder is that it tends to be a chronic and persistent course and early manifestation of symptoms. So it's really important that we have early recognition and early intervention to help change this trajectory. Okay, so we'll have a now look at the overview of the evidence for treating young people, and so I'll hand over to Steph for the next section of the webinar.
Thanks, Alex. Hi everyone, and thanks for joining us today. So the section that I'll be going through is to go through the existing body of evidence. So there is currently limited research on the psychological treatment of young people with social anxiety disorder. And to date, most of the interventions have been designed to target all anxiety disorder. And so research studies largely include young people with different types of anxiety disorders in the one trial. Currently, the treatment of choice for young people with social anxiety disorder is CBT. And while this is because CBT has the strongest evidence base, it's also worth keeping in mind that it's also the intervention that has been the most well-researched. So while some other psychological interventions aren't considered evidence-based currently, this is not to say that they are not effective, but rather that they have not been investigated enough for us to draw conclusions yet. Two CBT programs that specifically target childhood or adolescent social anxiety disorder have been developed. So there is cognitive behavioural group therapy and social effectiveness therapy, or SET. And these two treatment approaches share 4 common components. So they all include psychoeducation, exposure to the feared situations, skills to better cope with anxiety. So for example, teaching the young person relaxation techniques, cognitive restructuring, or problem-solving skills. And they all include homework assignments to consolidate or to facilitate consolidation of skills in real-world situations. Both of these programs are modeled after established adult protocols, and they're typically conducted in a group format. So while there are common elements across different CBT interventions, it's worthwhile looking at the differences in CBT protocols to see if these differences affect the effectiveness of treatment. Scaney and colleagues recently published the first meta-analysis on the effectiveness of CBT for social anxiety in young people. And this review is informative as they look at the influence of specific ingredients of a program on treatment outcomes. So this review included 13 studies with young people aged 6 to 18 years of age diagnosed with social anxiety disorder. And the primary outcome measure they selected was the young person's self-reported social anxiety symptoms. And the main reason they chose this is that there is good evidence that when it comes to assessing internalizing disorders, children are the most reliable raters of their own symptoms compared to, for example, ratings by parents. The majority of studies compared CBT to a waitlist control or attention placebo, so not to another intervention. And again, that makes it hard to say whether CBT is necessarily more effective than another type of psychological intervention. The meta-analysis found that young people who had CBT consistently experienced significant improvements or greater improvements in their social anxiety symptoms compared to those in the waitlist control groups. And this effect was in the moderate to large range, and the effect was maintained 6 to 12 months after the intervention. So this indicates that CBT has a long-lasting effect on social anxiety symptoms and suggests that young people develop a set of skills during the intervention phase, and they continue to benefit and use these skills even after the intervention is over. This review went further, and they investigated whether certain variables affected the strength of the therapeutic gain found with CBT. So they looked at mean age and found that the mean age of participants was not found to moderate the outcomes. Therefore, the current CBT manuals, or the manuals that were looked at in this review, can be used to treat both children and adolescents. A significant moderating effect was found for the number of treatment sessions and number of treatment weeks. However, total treatment minutes did not have a significant effect. And this suggests that the effectiveness of CBT is less dependent on the total amount of time spent in therapy and is instead more influenced by whether therapy is provided regularly and over a longer period of time. So for example, having 10 one-hour sessions over 10 weeks is likely better than having 5 two-hour sessions over 5 weeks. A key element which differs among the different CBT protocols used in different studies is the inclusion of social skills training. There is a hypothesis that people who have social anxiety also have deficits in social skills, and it is because they have poor social skills that leads to them then feeling anxious in social situations. And based on this theory, some programs then teach young people social skills. So they might teach them telephone skills, or how to express their opinion in a non-threatening manner, or even how to achieve an appropriate speech volume when communicating. And this review found that young people who received CBT with a social skills training component had larger improvements. And of note, the studies that were included in this analysis mostly delivered CBT in a group format. So essentially, group CBT with social skills training was compared to group CBT without social skills training. And as such, the results suggest that it is social skills training and not merely the exposure to a social group that was responsible for the improvements seen. And the authors concluded that social skills training is an active ingredient in CBT for social anxiety disorder. Some authors hypothesized that socially isolated young people are poor at generalizing social abilities learned in the clinical setting, and therefore they've added unstructured social time to programs to help participants transfer the acquired social skills. And activities could include going out for bowling or having pizza as a group. This review did not find that this component of CBT was a moderating factor. So giving young people the opportunity to practice social skills in a more natural setting does not seem to directly impact on social anxiety symptoms. CBT programs may also include specific sessions dedicated to parents. So for example, supporting parents with managing their own anxiety or helping them enhance their communication skills. Some models emphasize the role of parenting in the development and maintenance of child anxiety, but a 2007 meta-analysis on the association between parenting and child anxiety found only a very modest association, with parenting accounting for only 4% of the variance in child anxiety. And this indicates that there are likely other factors that need to be examined to better understand the origins of a young person's anxiety. And in this review, no beneficial effects of parental participation in CBT was found. The reason many young people with social anxiety don't get treatment is often not about issues with availability of treatment programs, and instead the nature of social anxiety itself might be a barrier to engagement. And to avoid this, some researchers incorporate the interventions into the school setting. This review found that while CBT in clinical settings and school settings both showed moderate to large reductions in symptoms, the effect size of school-based programs was much larger. It's possible that the difference between clinical treatment and school intervention could be due to differences in the populations included in these studies. So young people in school-based studies are usually identified through screening, whereas those in clinic studies are actively help-seeking. So it's unclear whether school-based programs are actually more effective than clinic-based programs, or whether the study population in clinic settings are more severe and complex and therefore harder to treat. So moving on from the Scaney review, what does the research say about group versus individual therapy? Group therapy would appear to have face validity as it offers in-session exposure to evaluation in a controlled and safe environment. And perhaps for this reason, treatment of social anxiety has been dominated by studies using a group therapy format. So is there evidence for it? And again, very few studies have focused specifically on social anxiety disorder. A meta-analysis on childhood anxiety disorders didn't find any significant difference between group or individual therapy, nor did a meta-analysis on social anxiety disorder in adults. There have been 3 randomized controlled trials comparing group and individual CBT for young people diagnosed with social anxiety disorder. So the first 2 studies in this table didn't find any significant difference between the different formats. It's worth noting that in the Herbert study, so that's the first study in the table, those in the group program received double the amount of therapy time and clinician contact compared to those in the individual program, yet there wasn't a difference in outcomes. And this is consistent with the Scaney meta-analysis we talked about earlier, where it is more important to have a longer overall period of therapy rather than having longer sessions of therapy. So the third study in that table, the 2014 Ingalls study, had different results, and they found that the group therapy program not only experienced higher dropout rates, but was also not as effective as the individual program. And this finding, or this result, was maintained even at the 12-month follow-up point. So let's look at this study in a bit more detail. And it's important to note that the CBT conditions in this study delivered different content. In the first 2 studies in the previous slide, the CBT protocol used was the same, and the only difference was whether it was delivered in a group or an individual setting, whereas in this study, group CBT was based on standard CBT manuals, while individual CBT in this study was based on the Clark and Wells cognitive therapy model. And while this model is not yet well established in the treatment of young people, it has good evidence for the treatment of social anxiety in adults. A focus of this model is on the cognitive processes that maintain social anxiety. The treatment also goes through individual case formulation and targets specific factors that, based on the young person's case formulation, is hypothesized to maintain their anxiety. Therefore, while this study's findings are interesting, the difference in effectiveness might be more about the content of the CBT intervention provided rather than on the format of the delivery. And based on their positive findings, adapting the Clark and Wells model for use with young people is worth further research. Another point to note is that the group therapy program had less sessions overall, but longer sessions, whereas individual therapy, that group had more sessions overall with shorter sessions. And again, going back to the scaling meta-analysis, the findings here are consistent in that having more sessions seems to be more important than having longer sessions. And what about other types of interventions? So research with adults suggests that up to 40 to 50% of people with social anxiety disorder referred to CBT show little or no improvement, and so there is a need for other treatment options. Cognitive models of social anxiety assume that attentional processes are important in the maintenance of social anxiety. So this could include hypervigilance, attentional avoidance, and a heightened self-focus. And while CBT targets a range of biases, attention bias modification is a type of therapy that targets a specific bias in attention. And this is based on the theory that in anxiety, there is a threat-related attention bias. For example, a person with social anxiety might enter a room and their attention is subconsciously and automatically drawn to the potential threats in that environment. They notice different things that someone without social anxiety might. ABM, so attention behavioural modification, is an attention training strategy to redirect the focus of attention from the self to focusing attention outwards, and it uses repetitive computer-based training to target implicit processes. The most common procedure in ABM uses a modification of the classic visual dot probe task. So in the classic version, two stimuli are briefly presented, for example, a threatening face and a neutral face, or a threatening word and a neutral word. And immediately after, a dot appears or probe appears in the location previously occupied by one of the two stimuli, and the participant has to use the keyboard to indicate the location of the dot as quickly as possible. An attention bias is when the participant responds faster to the dot when it replaces a threatening stimulus than when it replaces a non-threatening stimulus, indicating that their attention was directed to the location occupied by the threatening stimulus. In ABM, researchers typically modify the original task so that the dot or the probe nearly always replaces the neutral stimulus. So for example, in 95% of the trials, the dot will replace neutral words like dishwasher. And in that process, they redirect or retrain the participant to attend to non-threatening cues. And this process can be repeated hundreds of times in a training session. Early studies of ABM appeared promising and attracted a lot of interest, but when recent meta-analyses synthesized the evidence, the effects are not as large as originally thought. So a 2015 meta-analysis found that ABM only resulted in a small but significant improvement compared to the control group that did not receive an active intervention. And this small effect was not maintained 4 months after the intervention. And even though this meta-analysis isn't specific to young people, about half the trials had participant mean age around 20, and the authors also found that age did not moderate the effects. Another 2015 meta-analysis combined studies across different types of disorders in young people, and they found that effect sizes were small and non-significant for all symptom outcomes considered. So we've got a question here asking, am I right that this visual dot probe process is similar to conditioning? And yes, I would agree with that. It's a way of reconditioning people to switch their usual biases, their usual attentional biases, and reconditioning it to another way of looking at a situation. What the research is finding, though, is that this form of conditioning might work well in the short term. And they have found that following these studies, the attentional biases or outcomes related to attentional biases do seem to switch and do seem to change after this process of conditioning. However, in the longer term, those effects don't seem to last. And so a question might be that future research should look at whether maybe refresher training might be needed to recondition people over time as well to maintain those benefits as well. So now, okay, so another intervention that has been receiving interest recently is mindfulness-based interventions. And mindfulness is generally defined as a non-judgmental awareness of present moment experiences and can be considered a type of attentional training as well. Mindfulness might have an effect on social anxiety symptoms by training clients to gain attentional control or becoming more aware of their attention and increasing their tolerance of negative affect, which might then reduce ruminations and negative aspects of self-focused attention. Several pilot studies have looked at mindfulness training for adults with social anxiety disorder and found that it can reduce symptoms and improve quality of life. An uncontrolled trial of mindfulness-based stress reduction was just published this year with university students with social anxiety disorder. And after 8 weeks of classes and daily mindfulness meditation, so such as teaching them the body scan or hatha yoga, participants experienced moderate to large improvements in social anxiety symptoms and psychological distress. However, this trial didn't have a control group. There has been one RCT, so one randomized control trial published, looking at group mindfulness-based cognitive therapy with group CBT for young adults with social anxiety disorder. And I'll go through this study in a bit more detail as it's a unique study in that it compares two active interventions, whereas most of the literature in this area tends to compare an intervention to a waitlist control group. So this clinic-based study had a crossover design. So group 1 would receive the mindfulness intervention first and then go on to receive CBT, while group 2 would receive CBT first and then have the mindfulness intervention. The program was based on standard protocols, so standard CBT protocols, with the addition of individualized case formulations based on the Clark and Wells model. And even though the authors call it group CBT, participants also received 2 individual therapy sessions as well. The mindfulness intervention taught techniques such as the body scan and gentle yoga exercises, and participants were recommended to spend about 30 minutes each day practicing mindfulness exercises. Both interventions resulted in moderate to large improvements in social anxiety. And while CBT had a larger effect size, the difference between the two groups wasn't significant. The improvements in social anxiety symptoms persisted up to 6 months after treatment for both interventions. And one of the reasons it's important to find alternative interventions for social anxiety is that many young people don't respond to CBT. And because of the crossover design, all participants eventually received both mindfulness-based cognitive therapy and CBT. However, 42% of young people in this study did not respond to treatment, which indicates that combined treatment does not reduce the high numbers of people with unsatisfactory outcomes found in prior studies of CBT. The authors concluded that mindfulness-based cognitive therapy might be a low-cost treatment for social anxiety, although probably less efficacious than CBT. I'm a bit more cautious about the conclusion that mindfulness-based cognitive therapy is less efficacious than CBT. The results show that the mindfulness intervention had good outcomes. So while symptom scores were numerically not as good as CBT, they were not statistically different from CBT. The mindfulness intervention also appears more cost-effective as group sizes were much larger. So in the mindfulness group, they had 14 participants versus 6 participants in the CBT group. And the mindfulness intervention was much briefer as well. So they had 8 group sessions versus 12 group sessions in the CBT intervention. And a final point is that the group CBT delivered in this intervention might not be a good representation of other standard CBT protocols or other standard group CBT protocols. And this is primarily because of the inclusion of aspects of the Clark and Wells model, specifically the focus on individualized case formulation and the additional individual therapy sessions that CBT in this study included. So people in the group CBT program had 2 additional individual therapy sessions as well. If you recall the 2014 Ingalls study we spoke about, where we were looking at whether there was a difference between individual and group CBT, individual CBT based on the Clark and Wells model was more effective than standard group CBT. So it's possible that the effective ingredient in the group CBT program here is the Clark and Wells model or the longer duration of overall therapy. And when you consider these differences in the 2 interventions in this paper, it's actually quite significant that mindfulness-based cognitive therapy with its larger group size, less individualized focus, and briefer duration of treatment still performed as well as group CBT, and that the improvements were sustained over time as well. So just summarizing some of the take-home messages from today. So based on the current research evidence, CBT is the psychological treatment of choice for young people with social anxiety disorder, with effects maintained up to 12 months post-intervention. And even though no clear differences have been found between group versus individual formats, group CBT programs have a larger evidence base, as most CBT programs have been group-based. And CBT groups are generally kept quite small, with about 4 to 6 participants. Current CBT programs can be used across children and adolescents without significant age-based modifications. School-based CBT programs might be more effective than clinic-based interventions. And having more sessions of CBT spread out over a long period of time is more effective than having longer sessions of CBT. Social skills training is a key component that influences the effectiveness of CBT and should be included in programs. Having parents involved in treatment and providing unstructured social time for young people to practice social skills does not seem to influence the effectiveness of CBT. And the last point for CBT is that more research should be done to investigate the effectiveness of adapting the Clark and Wells model for young people with social anxiety. And in terms of other treatment approaches, while attention bias modification has received a fair amount of interest, it only has a modest short-term effect on social anxiety symptoms. And finally, the early evidence for mindfulness-based interventions is promising and appears as effective as CBT, with treatment gains lasting up to 6 months. The body of research is still very small, and more trials on mindfulness for social anxiety are needed. So those are my references for the evidence base. And I'll now hand over to Alex, who will go through a case example of intervention for social anxiety.
Thanks, Steph, for that very comprehensive overview of the literature. We've been able to see some highlights coming from that as to where we can see there might be some promise or some emphasis for working with young people to improve their social anxiety. So I thought that we'd just conclude before we get into some more Q&A with a brief case example of an intervention trying to focus, well, I was focusing on using the Clark and Wells model with this young client that I was working with. So James was a 19-year-old male and he had a 12-month history of social anxiety and intrusive thoughts. And it was the intrusive thoughts actually that was the reason why he was coming for therapy. So they commenced at the time that he sort of broke up from a previous relationship. He started having intrusive thoughts about his ex-girlfriend, ruminating on some of the hurtful comments that she made, and then ruminating over what this meant for his current relationship, and really concerned that he was betraying his current girlfriend with thoughts of his ex. So at assessment and in starting treatment, managing this rumination was his primary concern. He'd also slowly but steadily increased his cannabis use to approximately 1 gram daily and was regularly cigarette smoking as well. And he had commenced uni after finishing Year 12, but he had dropped out after the first few weeks due to stress, and he was working part-time in a bar. So he was well engaged with the youth mental health service that he accessed. But over the first couple of sessions, as I said, even though James's primary concern was around his rumination, it became apparent that he had significant impairment associated with anxiety, specifically speaking to his colleagues or spending time with more than one friend. And he often chose to leave events early, or he limited his interaction when he was at social events. And he also ruminated excessively following social encounters over saying the wrong thing or sounding stupid or potentially causing offence by something that he either said or failed to say. So some of these thoughts that James were experiencing, so we sort of identified them in that early work that we did together. So these are typical of thoughts of people with social anxiety. So what I say sounds stupid, everyone thinks I'm boring. This is specific to James. He was really concerned that he'll say something that people will find offensive, that people will notice him anxious, that he's anxious, or he won't have anything to say. So he was really motivated to work on social anxiety in conjunction with generally reducing his stress. So we used the stress bucket metaphor to explain some of this together, that many of the things were building in his life and causing his bucket to overflow. So for example, his increasing cannabis use, a previous bad relationship experience, not looking after himself physically at the moment, the lack of sleep associated with rumination, but also had a really poor diet as well. And following this sort of exploration, he really identified that social anxiety was his main problem that he wanted to work on. So the explanatory model for the persistence of social phobia that I was working on with James stems from Clark and Wells' work that Steph was mentioning in the evidence overview. And the biggest thing that we actually noticed was the use of James's safety behaviours. So these are actually behaviours that socially anxious people tend to develop and engage in, and they often have more than one safety behaviour, with the intention that these behaviours will help prevent the bad outcome. So for example, some people might, a safety behaviour might be excessive rehearsals. They might rehearse topics of conversation that they could have with people based on the news that they heard about in the morning. So it may provide them with a lot of content, but it often leads to some of these unintended consequences, such as those that are listed on the slide. So it doesn't give people the opportunity to prevent, it prevents disconfirmation, so they don't have the opportunity to see whether they can actually flourish or even tolerate the social situation without using this safety behaviour. It also increases their self-focus, and we heard from what Steph was reviewing as well that that's an important maintaining factor of social anxiety. It can cause the feared symptoms to happen, so you're concentrating so hard that it might induce some sweating or some shakiness as well. It can also have some contamination effects, so it can make you appear withdrawn or unfriendly depending on what the safety behaviour is. And also it can end up drawing more attention to your feared behaviours and yourself than you ever intended. So one of the things that Clark and Wells, and particularly Clark in his later work, really emphasises is this understanding of the safety behaviours and getting into conducting behavioural experiments around them to reduce the occurrence of them and to help people realise that they can actually cope in the situations without the safety behaviours. So here are some questions that you can ask when you're thinking about trying to assess around safety behaviours. So you might ask, when you thought the feared event might or was happening, did you do anything to try to prevent it from happening? Did you do anything to try to prevent people from noticing? Is there anything that you do to ensure that you come across well? Do you do anything to try to control your symptoms? And do you do anything to avoid drawing attention to yourself? So all of these probing questions can be used to help identify safety behaviours in people. So in working with James, we were able to work through and see some of the things that he did as safety behaviours. So for example, when he was on breaks during work, so he was working in a bar and they had a little area outside where staff could go outside to have to eat and to smoke and to have a break. So whenever he did go there, he would light a cigarette and smoke it as quickly as possible to be occupied. He'd concentrate on the cigarette and often look down at the ground at the same time. He realised, though, that smoking quickly actually caused him to shake more because of the effects of the nicotine and other things in the cigarette. He also stayed silent in case he said something that was stupid or offensive. And then he would leave the situation as quickly as possible, so before the end of the break, and sometimes spending the rest of the break in the bathroom. So over us exploring some of these to get an understanding of whether some of these safety behaviours actually ended up leading to that unintended consequence, James was able to actually see, as I mentioned, that smoking quickly actually caused more symptoms. Spending the long time in the bathroom was starting to draw attention from others as well. And over a couple of sessions of exploring this, he was able to question whether these behaviours actually made him appear that he didn't want to interact with his colleagues. So whether he was actually giving out the sense that he didn't want to be friends with them. So this was a big sort of insight for him to realise that his behaviours were maintaining the very things that he didn't want to happen. So one of the things that Clark really emphasises is the need to conduct behavioural experiments. So we did this to test whether James's fearful predictions in social situations did occur while he was trying to drop his safety behaviours. So one of the things that we did do was when he was out in the break concentrating on smoking slowly, and he noticed that that started to reduce his symptoms, and also spending time outside provided opportunities to learn more about his colleagues, finding things that were in common, so things that he was able to talk about. So when we broke that down, we actually did some predictions with that. So the situation was the break outside with colleagues. His prediction would be that if he tried to join the conversation, everyone will think he's boring, and he strongly believed that. So to test that prediction, the next time that he was at work, he was going to say the first thing that came into his mind, and he was going to stay outside for the whole of the break. So if he didn't leave to go to the bathroom, it meant that he could actually be around to see the person's reaction. So what was the outcome? So he did it, and he didn't leave. and he found that one co-worker responded to his comment and seemed interested in chatting further. So what he learned was that he's probably more interesting than he thought, and he moderately believed that. So we're sort of building on that over time. So that's just one example of a behavioural experiment that we did together. In conjunction with that, we also looked at some lifestyle interventions. So dietary changes. He's spending more time with his mother, and he is actually learning to cook a few meals from her, and that was a really nice time that they were starting to spend together. He found that he was able to reduce some of his tension and his stress by riding his bicycle to work, and he also started doing some weight training, and it increased his self-confidence in his appearance. So we had a short-term intervention of around 8 weeks. During that time, near the end of that period, James, because he was looking for work because he felt that part of his problems were really context dependent. It was really hard to stay in that bar job when he was so socially anxious. So he was always on the lookout for other work, and so he applied for and he was offered another job. However, he did then end up choosing to stay with his current work. He had developed some friendships, and he was realising that once he dropped his safety behaviours, he was able to actually enjoy break time and develop some friendships at work. He also commenced vocational study and was working hard at reducing his cannabis use and increasing his sleep quality as well. We also noticed at the conclusion of treatment that obviously in short-term interventions there's only a limited amount of time and what we can focus on, and together James and I had decided that the anxiety was his main goal, even though the intrusive thoughts were what brought him to treatment. But we actually noticed, without addressing those intrusive thoughts, that they did reduce to the point of not being a concern at the end of treatment, even without them being a focus. Okay, so that's the end of the case study. And before we get into seeing if we can have some more Q&A with you as the participants of this webinar, I would just like to mention that we've got some online training that's new to Orygen. So if you're interested, you can have a look at the website and find out about our certificate in young people's mental health and technology. And we also do offer on-site workshops and consultation services as well. So we've got introductory level to advanced practice or tailored workshops that can suit your workplace and your budget. And again, if you want to find more information, you can have a look on our website, or you can also contact our training team directly on that email address. Okay, so I will welcome Stephanie back to have a look at some questions that have come through in the webinar. So again, just excuse us for a second. We'll shuffle our chairs around. Do apologise. And then we can just see some of the questions that have come through. So I think probably one of the things that I was interested in that someone asked, Steph, was about when we're looking at what was coming through about mindfulness and in conjunction with CBT, and obviously the study that you were looking at, that particular one had it combined in the group-based format.
Yeah, but I go back to that slide as well while you talk.
Sure, but whether there's also potentially anything that's come from the literature that might say, similar to the way that we might use mindfulness in depression as relapse prevention, whether there was anything coming out of that. I know it's minimal because it was only the one study.
Yeah, so it's just the one study. So the question is whether would you combine mindfulness with CBT. So this study, the PIET study, does show that over time. So if you look at the graph on the right-hand side, it's a bit complicated. I've tried to indicate in colored lines to show the different interventions over time. So it does show that a combination of both CBT and mindfulness intervention does seem to result in further decreases in the symptoms of social anxiety over time. So the first lines, the first two colored lines sort of indicates the first phase of the study where they got one intervention, and then the second two lines indicates the second phase of the study where they got the next intervention. So it is showing that overall combined, the symptoms do seem to continue to improve over time as well. However, what they found was that even with that combination of having both CBT and mindfulness intervention, that didn't reduce the high rates of people who were treatment resistant in some ways. So combining mindfulness with CBT doesn't seem to change those statistics with that group of young people. So it might be that something more, another type of intervention needs to be explored for young people who have treatment-resistant social anxiety disorder. And the second part of the question is whether would you then offer mindfulness after CBT as relapse prevention. So going back to this graph again, so if you see the first group, the line in green, so they've received mindfulness during the first phase, and in the second phase, the orange line, they've received CBT. So for that group, there was a significant drop in symptoms from baseline to the first point, so after CBT, after mindfulness,
yeah.
And then in that second phase, they've received CBT, and there was another significant drop, even though it's a smaller drop, but it was significant. However, if you look at the other group, so the other group started off with CBT first, so they've got that orange line there where there was quite a big drop in their symptoms over time. In the second phase, so you could see that as maybe a relapse prevention phase where they're then offered mindfulness, so that's that green line. So even though their symptoms continue to drop, it's not a significant drop in symptoms.
Okay, so we're looking at difference in the slopes there and seeing that the improvement from those who received mindfulness second was not as significant as those that received CBT as the second intervention.
So it's actually the other way around. So the people who received CBT and the second intervention continue to improve.
Yes.
Whereas mindfulness doesn't seem to be effective as a relapse prevention strategy.
Okay.
Yeah.
All right. So we've also got a question about cross-cultural groups as well. And I suppose that's getting back to more, not so much the interventions, but thinking about the description of, or the, characterising what social anxiety is like in young people, and understanding where to draw the line between being shy and when it becomes socially anxious.
Yeah.
And I think that's probably one of the questions that is a key thing in the literature around that difference between temperament and when it becomes a disorder. And I think one of those things is that it also just is characterised by the diagnostic manual at the time. But one of the emphases that consistently happens in diagnosing social anxiety disorder is about the level of distress and impairment that it is causing. So sometimes, even though some people who are shy have incredible amounts can have discomfort in social situations, the level of avoidance and the distress caused by encountering social interaction is not as strong as with social anxiety disorder. But I think that probably too what we can see from what we know from the literature is that there is insufficient amounts of research that's done cross-culturally across all areas in youth mental health, actually, not specific to social anxiety disorder. So I think that there's a long way to go, actually, to understand the difference, particularly in knowing the difference between what happens with what would be more an independent culture that's predominantly in Australia versus an interdependent cultures, perhaps in more Asian or cultures, and understand the difference there.
Yeah, and I think it's also the impact it has on the person's functioning as well, and whether they're distressed by it. So the question was, where do you draw the line between shy and social anxiety disorder? And someone might be shy, but they can continue to function, and it can be still lead quite productive and fulfilling lives, and it doesn't impact on their day-to-day functioning. And it's also, if that behavior is appropriate culturally in that environment, then that's not problematic as well. Because if you think of the diagnostic criteria, so previously it was about the person who was experiencing the anxiety, they needed to recognize that the anxiety was excessive or unreasonable. Whereas now it's more about whether people around them can make that call, or people around them can make that call whether it is excessive or unreasonable. And if culturally those behaviors are not seen as problematic, So shyness might be interpreted in a different culture as being quite reserved or quite respectful, and that might not be seen as a problematic disorder as well.
That's right. Thanks, Steph. Great response. Just scrolling my eyes over the questions that have come in, and I think that perhaps we have addressed most of them. A common one that does come in is about thinking potentially about sort of third wave interventions. So we've now got a question about using acceptance and commitment therapy for social anxiety, particularly as it does more often than not include a mindfulness component in that. But I think at this stage I'm pretty confident that what Steph is going to say is that there hasn't actually been any intervention trials into this.
Not that I know of. And I can see how ACT will be really helpful for helping a young person be able to sit with those feelings of discomfort. However, what's come up from the literature so far is that a really effective or core component of treatment seems to be that social skills training component. So some element of training, I think, is still needed, whereas in, I think, acceptance and commitment therapy, there's less of that aspect as well.
Okay. That's a very good point. I think that probably also just reminded me to mention again, and I know I did at the start of the presentation today, was that a way to keep up to date with this rapidly growing area is to keep checking out our evidence finder database. So we do update it on an annual basis, and we work behind the scenes. It takes quite a lot of careful and considered work to get this job done. So what we've done is we ensure that we've actually got all the intervention literature that's applicable across any disorder that affects young people. We've coded it by the stage of illness, so is it a prevention study, for example, or is it a relapse prevention, or right through the spectrum. And we've also coded it by the type of intervention. So you can search quickly for acceptance and commitment therapy across disorders or on specific disorders, and you can actually see what studies have been done for that therapy quite quickly. So it's a way of you ensuring that you don't need to actually go to PubMed or to Google Scholar or whatever other resource you'd normally be using. You can actually find the literature. And we've worked out, I think, pretty much that we end up with what you can search independently. In the end, once we've all coded it, we end up with about 1% of what you find in a general search actually is included in our database. So to flip that around, we get rid of 99% of the irrelevant things for you guys so that you can keep in touch with the current intervention literature.
Lots of fun. What's happening at the moment is that we're currently going through an update. So very soon, hopefully in the next month or so, the database will be updated with literature published in 2015. And we'll also be modifying or updating the database so that it'll be more user-friendly and have more functions available as well. So you can find that on the Orygen campus website.
Right. Thanks, Steph. I should also mention that it actually is a project that we do in conjunction with Headspace, the National Youth Mental Health Foundation. So it is also, that information is also available on the Headspace website as well. Okay. Well, at this stage, I don't think any more questions have come in. So I'd like to actually say, and I'm mindful of the time, sorry, I've just realised we've got a couple of minutes over. The clock on the wall is very different from real time. So thank you very much for joining us today, and I'd like to extend my thanks to Steph for preparing such a comprehensive overview of the literature. As we can see, it really aligns closely with that work that she's doing with our evidence mapping project, just to get a sense of what do we understand about those interventions that are effective in young people. So just to remind you too that the slides will be available within a couple of weeks on the website. And anyone who's registered for this webinar will be reminded of that when the slides do become available. I'd also like to mention the next anxiety-related webinars. We've got a bit of a series happening at the moment. So in 2 weeks' time, Shona Francie will be presenting around social anxiety, stigma and early psychosis. And then the following fortnight, we've got Ben Harrison from the University of Melbourne talking about the neuroscience of anxiety disorders. So a couple of very interesting webinars coming up to round out our short series on anxiety. Also, some more webinars later on, just to remind you what's coming up in April and May. Our series then will focus on physical and sexual health and mental health in young people. And we've got some presentations by Dr. Melissa Kang and also by Dr. Brian O'Donoghue from Orygen. So we've got a couple of interesting webinars coming up over the next couple of months. So thanks again for your attendance. We hope that you found the information valuable and useful for whatever work that you are doing with young people or in youth mental health. And as I mentioned, the session's recorded, will be available online, and you'll also receive a certificate of participation as well. So once again, thanks for your time, and hopefully you can join us for the next webinar.
Thanks, everyone.